and welcome to the third episode of the Impact series. My name's Charlie Webster and I'll once again be with you throughout. Across the Impact series, we'll be speaking to a range of incredible individuals, both known and unknown, who have all contributed firsthand towards the fight against malaria and whose contributions have impacted people's lives and important research. These contributions can include new scientific advances, tools, policies, funding, level of awareness, and of course, very important, voices. Our aim is to highlight the work and the people who are working across affected countries, in addition to the values we hold dear, the speed of response, delivering with precision and responsibility, as well as our focus on positively impacting others. We're hoping to really unfold the challenges and understand the doubts, whilst realizing those aha moments and finally understanding what in the end has enabled and will enable success in the future. In today's episode, we have the pleasure and absolute privilege of speaking with Professor Rose Leke, Emeritus Professor of Immunology and Parasitology at the University of Yaoundé and Fellow of the Cameroon Academy of Sciences and Doctor Honoris Causa at the University of Ghana. Welcome, Professor Leke, and thank you so much for joining us. I was going to say, everybody give a huge round of applause at home who's watching. It's an absolute privilege to have you here.
Thank you very much, Charlie. Thanks for having me here on the Impact series. It's a pleasure for me also. And to discuss malaria. Yes, thank you.
Yeah, you're an absolutely extraordinary woman. And for me, a huge inspiration. And I know for many, not just in the field of malaria, but also the field of women in science. What was your inspiration? Does it come for you from childhood, from your upbringing to go into this field?
Well, my inspiration was really, I should say, my family, my father. Even though that was a period where women were not going to school, I had to go to school and I had to do the best. So I think from the beginning, that was the start of it. It's my parents. And then the environment also, that he was a school teacher and he would, in the evenings, he would really get me saying, what had I done in class, like revision with me, encouraging me and helping me out. So I had that opportunity also with my father.
That's incredible that your father was so, kind of saw that potential in you, but also believed in the role that women can play in science, in research, in education, in the workplace. While we're on the subject of women, can you talk to us more about Hire for Women, which I know you founded in 2015, and how important that mentorship is?
It's not just mentoring in science, in the career, in the scientific career, but it is, we call it holistic mentoring. We've written about this even in Nature, The Lancet, and so on. Meaning my protege can call me at any time and get advice on anything. We've had such an impact, I cannot tell you. Those who tell me I had given up, I was going to be a mother and just stay there, not do research. And now they are writing abstracts, sending places, and going all over the world. And it's so, it's so fulfilling for me and for the other senior scientists. And then we graduate. Those who do so well as mentees, we graduate them to mentors. So we have now many younger mentors, like our Secretary General now tells you her story. She's in agriculture and she's so vibrant. She was a mentee, now she's a mentor. And they just take it so seriously. So we were doing that for the career for the younger scientists. But then during the Women's Week, we do an outreach. Last year, we went to secondary schools and talked to the secondary school, about science and so on. And this year we decided, let's try the primary, those that are getting older, because that's where they start having the idea. So 2 days ago, the Cameroon Tribune, a national paper, just have me there now. I'll send it to you. It's so beautiful what they had to say, and I'm just holding something up and talking about where all the Hire women and all those children were there. It was really wonderful. So that's Hire, and the women are so committed. What we lack more is funding, but sometimes I just sponsor some of these things on my own. And then some of our contributions We do a little bit of contributions yearly and it goes in. That's the story of Hyatt.
Professor Leke, when I asked you that question, I love how much your face lit up and the big smile, and you can feel the passion from
Yeah,
you. And the
very.
fact that it's a holistic approach and
Yes.
it's done in a sense of community, I think is so important. And in terms of leadership, one thing I always think is for younger people to see the vulnerability and authenticity and struggles that people in your position have had, because it makes you go, like you said, oh, I can do that. You know, it's not abnormal to feel those things. And I just want to say that HIRE stands for Higher Institute for Growth in Health Research for Women.
And did you see the logo, Charlie? The
No, what's the
logo,
logo?
yes, the logo has an older person. It's a ladder, if you look at it.
Right.
And the older one is on top of the ladder and holding onto the other and pulling her up.
Oh,
That's what the logo is.
that's
I'll,
so
send you the logo and the ladder. We just, and they're great. They are so committed. And that's how we move on. That's it.
Yeah, that's so inspirational. And in terms of like
networking, absolutely. Networking among them. You know, do you have, who knows where this is? How do you write an abstract here? I sent this, where do you know? I mean, the forum, you should see how every single day people are helping each other, asking questions, answering them, and wonderful. For COVID times, when we couldn't meet, we met at least online, talk about COVID-19 and so on.
And
So it's very resourceful. Yes.
That holistic approach is wonderful, because life happens. It doesn't happen separately to work. It happens.
The editor of Nature, I was in a meeting in Dakar, and the editor of Nature really came behind me looking for me. You know, he wanted us to write. So we wrote. We have it in Nature. We have it in the Lancet. Just talking about, you know, our own kind of mentorship that we do. It's working very well. We hope we can extend it to Central Africa if we can get some funding for that.
Absolutely. Well, anybody watching, there you go. Here's your opportunity to really help the future. In terms of malaria, Professor Leke, what was it about malaria? Like, I presume you were surrounded with it when you grew up.
So malaria, I've lived with it. I've grown up with it. And, you know, I went on then to university, and I had in mind I had to work back in malaria. And when I had finished my bachelor's in St. Mary's, I got a place at University of Illinois to do a master's degree there, where Dr. Paul Silverman at that time, blessed memory, he was starting on the malaria vaccine. So I was on the malaria vaccine project. That was in 1970, who believe it has taken so long. So, and from there, then I went to University of Montreal and worked on malaria, mouse malaria, for my PhD. And coming back to Cameroon, I started out in onchocerciasis because we had an institutional strengthening grant in it, but I know where my vision was, where my mission was malaria. So I wrote a project for USAID and, you know, got a grant, but they wanted me to have an American partner with me, collaborator. So they looked for Dan Taylor for me in Georgetown. That's when my collaboration started with Diane. And then we worked on malaria in pregnancy, malaria in the population. We wrote grants, you know, got some money to do work on malaria in pregnancy. There were 4 women that started out in Georgetown and then, you know, over here. So that's how my malaria research life has been. And working in villages around here, you know, around Yaoundé. And in the summers I spent as adjunct professor in Georgetown University, you know, continuing to do some work. And we did quite a bit in malaria in pregnancy. Yes.
So, because the thing about malaria is it does impact the most vulnerable, children, newborns, and pregnant women. So what did you learn in that period when you narrowed that focus to pregnant women and newborns with Diane Taylor?
Yeah, with pregnant women, you know, that was interesting. We first could show that, you know, it had been shown about, Frida and Duffy had talked about having the placenta being the home of malaria parasites. You know why this pregnant woman, you don't stand so.
Right.
Here, my husband is an OBGYN. We went and we got about 1,000 women at delivery. You take the blood you take the placenta and you take peripheral blood. And we found out that in about 25% of those women, in the peripheral blood, you didn't find any parasites when they were delivering, but they were in the placenta, meaning that they were missing a lot of these, when you did look for it here, there was a lot in the placenta already. So at that time, diagnosis was mainly by microscopy. So we had to go and sensitize the gynecologists and the people taking care that, look, even if a woman doesn't show parasites in the peripheral blood, it could be this amount in the placenta, so they have to look out for that. So that's what we did. We did a lot of work in the placenta malaria itself. And then in the villages, we went around, we had longitudinal studies following mothers and then also following the children. And because these children that we had, and because they were in a project, these children, were following up the mothers with when you follow them that much, they don't have as much malaria than the others also in the population. But we're able then to look at mothers, look at children, and later on in life, look what's happening with some of these children. One thing also you see is having grants. These grants, you do 5 years, it goes, 5 years, it goes, and when it stops, the work stops.
Yeah.
So
then how important is it to make sure there's that sustainability of funding for research? Because if you do that for 5 years, then there's only so much you can learn and then implement.
I've been in meetings where we've made recommendations that grants should be for at least 10 years and give the person time, even if it's 5, 6, 7 years, give them some grants, even, to finish up the next 3 years, write the papers and write other grants and get it so you can continue. But there's this whole thing about 3 years and 5 years and so on. It has stayed on all the time. And you'll find out in many African countries, when the grants finish, that's the end, of that program, of that work, of that thinking, of that whole science, and everything just falls apart. It's too bad though. African countries should start putting quite a bit of money into research. There's too much external, all of it is, I'm talking grants, external funding.
Actually, why do you think it's not seen as a priority? Because almost that's the answer to how, right? If it's seen as a priority, then you will get the funding. So it's almost like, why isn't it seen as a priority? Is it because funding, say, goes into the transport system or roads or infrastructure rather than into things like research, as in local funding?
What is priority, right?
Yeah.
And I think it's the understanding also. Take like for malaria, all infectious diseases, yes. But for malaria, we believe, everybody, you live with it. It's nothing that will ever completely go. We have that mentality. You have malaria, you take your drugs. If it's bad, you slip down a few days, and then you go back to work. Now that we're starting to talk, we're trying to get the elimination, like we started rethinking malaria, thinking, how do you get the concept of elimination into the people that, listen, you don't have to just live with it. You can get rid of it. To get the people to understand that, to own that concept that, listen, we have to work to really make malaria go. And maybe then, if it's for malaria, maybe some funds may come in. So I think, it's necessary. And countries are thinking about that, going that line, which is good.
One of the things, it's interesting you said that, because, Professor Leke, that I had malaria in 2016. And for me, I ended up critically in a hospital. We were talking about it for months. I ended up in a coma on a life support machine, had lots of problems and multiple organ failure. And for me, it was horrifically life-changing. And then I remember going to Uganda, and it was, malaria was almost normal. And for me, it was like,
That's it.
it it nearly killed me. It was like, oh
Right.
my gosh, malaria. And I went on this journey to learn everything there is to know about malaria, to become an advocate. And then I step in Uganda and everybody's like, yeah, malaria is just something we live with every day. It's
Absolutely.
interesting that
That's it.
you touched upon that, because I'm like, there's
Yeah.
almost that acceptance.
It's accepted. We live with. So when you tell people we can get rid of it, so that's job that has to be done to get that kind of ownership. We can eliminate malaria, that first, into the heads of the people, and then let's work for it. So there's a lot that is being asked now of the community.
Yeah.
Community participation, community involvement. And this is what Rethinking Malaria also came up with when they did the working groups, talk to frontline workers in Africa mainly about, what, trying to get some recommendations. And the community came out very, very, very strong. Get them involved, get the information there, let them accept it, let them buy it, let them own it. And then it's in that community also that you can have the hygiene and sanitation, that you can have the people, the community health workers working in there with the people, to be able to do something about this, reduce the burden, and then go on, talk about elimination where we are right now. Yes, I'm glad you had that experience in Uganda. This is how it is. And
Yeah,
that's why it's so much more difficult.
Professor Leke, what other major challenges do you see in regards to the fight to eliminate malaria at the moment?
Here in Africa, when they get sick, where do we go to first? WHO had years ago, I'm sure it's not the same statistics, it used to say 80% of the time people will go first to the herbal doctor before they go to the hospitals. So this, where do you seek help, first of all, is really also one barrier, because the children are taken there. By the time they're taken to the hospital, it might be too late. And that's why we have, so many. So that's one very important aspect, where we're hoping that if you get the community health workers to teach the people more, to be able to take them to the right location where they should be going, hopefully that can help it. So you need these community health workers all over. And then also political will is a big one too, because you need that kind of political leadership. And that's where it comes to, when we talk of even the resources, you want local resources coming in, you need to get good political will there too. And then capacity, whether it's financial, whether it's human resources, building this kind of capacity in the areas, even for the nurses, for the frontline workers, for the community health workers, and then collaboration between research and the decision makers, policy makers. You need that in country for people to work together. So you're getting evidence here that can also inform policies.
So what do you think are the real implications of insecticide resistance?
To what extent that resistance will reduce the efficacy of the LLINs, we're not sure. Resistance, you're putting it all, distributing the nets.
Yeah.
Then if you have resistance there, what impact will it have? How will it reduce the efficacy of these nets that you are putting on? I think those are areas that one really has to go in, and there's research needed in these areas. Without that, we can just go on. Resistance is somewhere, the nets are being put out there, and IRS is going on in some places. Because entomologists tell us, the resistance is really growing. And it's not only resistance to, by the mosquito resistance, mosquito to the insecticide, of course, also resistance of the parasite to those drugs that we have. That's why I put my head and I say resistance is such a problem.
Yeah. What has On a positive note, what has changed for you over your career? What do you think the biggest impact has been in terms of steps towards elimination of or eradication of malaria?
Yeah, I think right now what is changing is more people are becoming aware.
Yeah.
Yeah. And I can say, like in my country now, when we had Stop Malaria, I mean, the more people involved, more people getting aware, and then maybe the private sector is going to come in more than it ever did. We have more younger people also going into research. Though when we train them also here, the thing is you train them, they're so good, they go overseas, there's either brain drain or brain gain, whatever you call it, and then we lose those human resources. But there's more training going on, capacity building here on the spot for some of what is needed as human resources for some of this. So you see that. And I think, with the in rethinking malaria, Harvard University, I could share this with Professor Diane, what the rethinking malaria that has those working groups come up with 9 manuscripts that are now, they're really going to be there in the Harvard repository, but going to be published. I think there's so much information there, and that people, the awareness creation, I think at this point, that it is possible to eliminate malaria, I think is one thing. All we have to do is come up with those game-changing strategies. That's what we're trying to see. What was working, what didn't work,
Yeah.
how can we get to change what didn't work to what works, with meaning, what is the game changers, what are those strategies? And now the biggest thing is, now at least we have a vaccine.
Yeah.
Which is, people talk about efficacy, but at least that will protect death from, quite many African children. The trouble with that too, the vaccine is there, wow, the first vaccine, and others are in the pipeline coming in. So, there is hope in that. At least that in my lifetime, I see the malaria vaccine. I had a lot to do with that when I was in the MPAC, in the first, we were the founders of the Malaria Policy Advisory Committee. I had a lot to do with that when it just came out, but RTS at that time. But now it is there, and WHO has said, here is a vaccine. So to me, that's hurrah, we have that. And so can we use it? Do we have enough? I think that's the next thing, Charlie. We need about 100 million doses.
Wow.
And how many are we getting? We're getting 7 million to 50 million maximum for the next 2 years or so.
Wow.
So you can see where we are with that. And WHO is really working hard to see who gets it, who doesn't get this. How do you decide on who gets it and who doesn't get it? I happen to be in that whole thinking, tank and so on.
Oh.
So the vaccine is there, and hopefully it can be used by, at least for more children. It will prevent deaths in many African children. But the hope also is that other vaccine candidates are there, and they are coming. So we look forward to that. There's the positive part, yes.
What needs to change to make sure that there's more vaccines? So you said there's a huge gap between 7 million and 100 million. What needs to change?
Number one, that the suppliers, that enough pressure is put into the suppliers who supply more. But I think, right now, there is on the Africa CDC has a huge big grant to produce vaccine production on the African continent. And in me, I'm hoping, and I think WHO is working with the Africa CDC, so that at one point we can get these vaccines being produced here on the continent. Those are also positive aspects to look about. There's more and more people coming into health. I think that came from MasterCard, I think, for Africa CDC, if I'm not wrong. And so others hopefully will come in also and help the situation. So we can get enough supplies when they see that they're really preventing death in so many African children. Maybe others will come in also and decide to help.
Yeah, there's so many positives there. I know we've talked a lot about the challenges, but there is that
Mm,
hope and positives. One of the things I'm always intrigued by, and I've been asking everyone, Professor Leke, is you know, compared to you, I'm very green in the world of malaria. And like I said, I've done some awareness and advocacy work, and I hear quite often dates put on goals of eradication.
mm.
So at the moment, global expert, and I've seen those dates change in the short term I've been involved in malaria field. And at the moment, global experts believe that malaria could be eradicated by 2050. One, do you think we can eradicate malaria? Do you think that goal is realistic? Do you think the dates are important? And what do you believe it's going to take to do that?
I chair the African Regional Certification Commission for Polio Eradication. The date for polio was 2000. You know, I would never again for any infectious disease put a date. I think we just get working. And I think you can still be so committed in doing the work without putting a date. Maybe sometime will come in malaria where a date can be put on. I don't say no to that. But seeing what we have now as the burden on the continent, seeing all the other challenges that they are in Africa, we have the high burden high that is 10 in Africa and then India.
Yeah.
Seeing all that and what's coming in, COVID again coming, are you joking? There is no way I would even dare to put a date to it. Let's see the burden really reduce, find new strategies, game-changing strategies that can do better. You know what? It stalls. You know that. Progress has stalled a lot within the last years. So find something where we will see it really descending, going down, and then maybe when those strategies have been found, you know, and we have more of the vaccines, vaccine is very important. Maybe when we see it really going down at a level, we can say, yeah, maybe by this year it will be gone. Then I will not be alive again, maybe, but at least then a date can be put, something like that. But Charlie, I will not put a date on the limit, especially for malaria, and say malaria eradication for this date. No. I've had the experience.
Yeah, that's a really, I've not heard that before. That's a really powerful way to put it, and especially comparing it to polio. Final question for you, Professor Leke. You said that progress has stalled. Why is that? Is that being around the COVID period? Or was that before?
It's not only because of the COVID period. COVID has also had its own effect on malaria. You know, people not going to, just not going out to the clinics, women not taking children, out for treatment and so on. And that's when you really wish you had just the community health workers, all of them all over. Sometimes there's, no drugs, stockouts and so on. But progress really has stalled. And that's a question that is being asked. Because if understood what really one should do. That's why I said we had Rethinking Malaria. Yeah. And WHO now is taking it up also, all the recommendations from Rethinking Malaria to move it forward and put in whether it's the communities. We're also talking about associating research, universities with the policymakers and so on, so you can get evidence and put it in. So, but progress, that's a good question you've asked. Why has it stalled? The interventions are there. They've been distribution, global fund distribution of the ITNs all over. There's been IRS and they've been, but progress has stalled. So all this, we have to find out why has it, which we're trying to find out. And then how can we move forward? I think that's the point where we are.
Yeah. Thank you so much, Professor Leke. It's been a really powerful conversation and amazing to hear your huge contribution towards, the fight against malaria and talking us through where we're at the moment. Thank you so much. I'm so grateful. It's been an absolute pleasure. And And, I'd love to keep me posted about higher, because it sounds amazing. And, the impact that that's going to have down, in the future is going to be huge.
Thank you. Thanks, Charlie. It's been such a pleasure talking with you about higher. That's, we say, when you say higher women, we say, still we rise. That's what everybody, and we taught the children, other children were screaming the other day, higher women, still we rise. So we're still rising, there's everybody rising. So thank you so much, for this conversation about higher, and then about malaria, which, has been my lifetime. Polio, I was just there as an immunologist doing it. But my research, my lifetime, mission, vision, everything. And the last thing I'll tell you is when the man in the village said to me, "You've been coming here for over 20 years. Have you seen any changes?" Because there in that village, they're still getting malaria, like it was. Nothing much had changed. Can you imagine how piercing that is? Oh. Because, it's about the cell. What has happened? Like sometimes I say, did I fail? Did I do anything much? But also, like we said, there are the positive parts of it, Charlie.
Yeah.
So thanks so much for making me talk about my vision, my mission, and how far we've gone. I don't know if I've gone any far, but that's it.
Well, I really think you have, and so many people, I'm sure, think that, but it is really piercing when you gave that example of, the people that are actually living with it on a day-to-day in villages at that last mile, where it's like, what has changed? But there's so much that's changed, and your contribution is exponential. So thank you so much. And thank you all for watching this episode of the Impact series. I really hope today's conversations provided really important insight. And I think it's been a real prompt for impactful conversations. So powerful. And still we rise. I had to put that in. You'll be able to follow the Impact series. Yeah, Still we rise right here on the Vestergaard website, where you can catch up with the previous episodes again and look out for more on this crucial topic. Thank you so much. See you soon. And thanks so much again, Professor Leke. And still we rise.
Still we rise, Charlie. Thank you so much. We're still rising all the time. Thank you very, very much. And thanks to the audience also.